injury, and then look to see whether exercise and physical activity can start offsetting some of these changes. I'm going to use exercise and physical activity a little interchangeably here. Most people do. Exercise is really some kind of structured activity. Physical activity can encompass a wide spectrum of activities that really just require energy expenditure, but for the most part, they're used interchangeably. So I think Liz covered this actually really nicely in the very early part of the introduction. And if we take a look, this is some work done by my colleagues at ICORD, where I am in Canada. We did a big cardiovascular health survey across Canadians with spinal cord injury. We just looked at the risk for cardiovascular disease in people with spinal cord injury against people without spinal cord injury. And what you can see quite nicely is if you look just at heart disease or stroke, there's a really significant increased risk, anywhere between 4 and 6 times. And this risk remains even when you take into account some of the traditional risk factors like cholesterol or smoking or blood pressure. So there's definitely something about spinal cord injury that predisposes individuals to an early onset and increased risk for cardiovascular disease. Now, those people that work in spinal cord injury will know that when you have someone with spinal cord injury, they would typically get given a level of injury. So this could be a cervical, a thoracic, a lumbar, or a sacral injury. And then they'll be determined via a neurological exam to have either a complete or an incomplete injury. Now, this is the form that's typically filled out. This is the standard neurological classification form. And I've really highlighted the 2 key tests that are done. These are tests of motor function, and these are tests of sensory function. Now, what this means is that somebody with an incomplete injury may have preservation of sensory function, may have preservation of motor function, whereas someone with a complete injury may not have preservation of either of these 2 things. But what this exam does not cover is how complete the injury is to the autonomic nervous system. So one of the reasons for this is it can be exceptionally complicated to try and figure out the autonomic nervous system. But pretty much every organ in our body is under control. So our autonomic nervous system is like our automatic nervous system. It kicks in and it keeps our organs going without us really needing to think about it. It's really complex in how it's innervated. But 2 of the main things I'm interested in is the heart and the blood vessels. And so we're going to take this more complicated one and kind of distill it down to a more straightforward look at how the autonomic nervous system innervates these organs. And this is going to be really important for understanding the cardiovascular system after spinal cord injury and how it responds to exercise. So if we take the heart, there are 2 types of nerves that go to control the heart. One is called the parasympathetic nervous system, and these nerves do not travel down the spinal cord. So no matter where the spinal cord injury is, the parasympathetic nervous system, so this is what's responsible immediately for slowing heart rate down, and it exits again above the spinal cord. Now, from the heart's perspective, the other nerves that are important are called the sympathetic nervous system, and this does the opposite to the parasympathetic. So this is your fight and flight system. It's your excitation. So this is what's going to be responsible for increasing heart rate. The major difference here is that these nerves first travel down the spinal cord and then they start exiting the spinal cord in the thoracic level. So what this means is if you have somebody with an injury in this cervical region, that the control from the brain over these nerves to excite the heart is lost. And so we're going to cover today how this changes how the heart responds to exercise. If we think about the blood vessels in the upper extremities are also innervated from those same spinal levels. The blood vessels really only receive this sympathetic innervation. So as you exercise, these sympathetic nerves get excited, the blood vessels constrict, and our blood pressure goes up so we can deliver more blood and oxygen to the muscles. In the abdominal region and the lower legs, these blood vessels are innervated from lower spinal cord sections. So the big take home here is if you have an injury in this cervical or high thoracic region, anywhere really above T6, then your ability to increase blood pressure, heart rate, cardiac contractility during exercise is significantly attenuated. And so you can imagine this has some reasonably severe implications for both our blood vessels, blood pressure control, the heart, and as we're learning more and more, the cerebral vasculature as well. And so for the rest of this presentation, I'm really going to focus on what happens when spinal cord injury occurs above this T6 level, so anywhere in the high thoracic or cervical spinal cord. So here's probably one of the best examples. This was some work I did back in preparation for the London 2012 games. And so everything you're going to see now is in Paralympic athletes. And essentially what we did is we took these athletes, we had them laying down, we were measuring blood pressure, and then we essentially just sat them up and supported them in the seated position. And then we measured what the blood pressure response does. And so I'm going to show you 3 different responses here. I want to emphasize that all 3 of these have a C6 spinal cord injury, and they were all considered complete. So an American Spinal Injuries Association impairment scale of A. But again, remember, this is just motor and sensory completeness. So for all intents and purposes, these 3 individuals presented the same way. When we did this upright tilt in one of them, you can see blood pressure does pretty much what you would expect in an able-bodied individual. If anything, it goes up slightly. So they were supine, we sat them upright where this gap is, and then we looked at the blood pressure over the next 8 to 10 minutes. Another individual had a pretty significant reduction in blood pressure, but they were able to maintain their blood pressure here. The third individual suffered really bad orthostatic intolerance, so their blood pressure just dropped, and they actually fainted. And so this is here what we would class people that have severe orthostatic hypotension, so an inability to maintain blood pressure in the upright position. And this is pretty prevalent among individuals with the high lesion spinal cord injury. As you can imagine, if they don't have that sympathetic nervous system, they can't constrict those blood vessels to maintain blood pressure. One of the other things that affects individuals with an injury at or above T6 is something called autonomic dysreflexia. I'm sure most of you are familiar with this that are on the call, but what this is, it's a phenomenon that's unique to people with high lesion spinal cord injury. And it describes where blood pressure just continues to rise in response to some kind of noxious or non-noxious stimuli below the level of the injury. This can be anything from a tight belt to a full bladder to a full bowel. And so you can see this here measured in someone with spinal cord injury. Blood pressure typically is quite low, and then you have this sensory stimuli come in, and then blood pressure just spikes. And blood pressure can go really high during this. It can go anywhere up to 300 millimeters of mercury. It can be life-threatening in nature. And certainly for healthcare workers, it's important to remember that blood pressure can be quite low in people with spinal cord injury, typically around 100 to 110 millimeters of mercury. So if you have someone with a cervical spinal cord injury and their blood pressure is 130, 140, it's very possible that they are having autonomic dysreflexia at this time. For those interested, I'm just going to cover the way autonomic dysreflexia works. So essentially, if you have a lesion here above T6, there would be some kind of stimuli below the level of the injury, and that makes its way into the spinal cord. It then travels up the spinal cord, and it actually excites all of the nerves in the spinal cord. And so those sympathetic nerves get excited, they cause constriction in the blood vessels, and therefore blood pressure continues to go up. Now, in able-bodied individuals, that blood pressure would be sensed, and it would go to the brain, and then it would tell the brain to slow the heart rate down and to dilate the blood vessels. Of course, with the spinal cord injury, that response doesn't happen. So you can get the slowing of the heart rate, you do not get the dilation of the blood vessels. And so for as long as the stimuli keeps going, you just keep getting constriction in the blood vessels, and the blood pressure keeps going up and up and up and up until you find whatever the stimuli is. AD is very common in people with the lesions above the T6 level. Anywhere up to 90% of people with cervical or high thoracic spinal cord injury can develop autonomic dysreflexia. It's typically more common in those with complete injuries, but as I said before, just because someone has an incomplete injury, it doesn't mean that their autonomic nervous system is still functioning well. So it can still be pretty common even in individuals with incomplete injury. And again, just to reiterate, this can be quite important because if it's left untreated, it can lead to stroke, myocardial infarction, and there's actually about 40 or 50 cases of death directly related to autonomic dysreflexia around the world. So this, along with the orthostatic intolerance, can lead to some pretty severe blood pressure instabilities for people with high lesion spinal cord injury. One thing my lab has become interested in is changes in the heart itself. And so we've measured this in people with spinal cord injury. You can use ultrasound and you can measure the size of the different parts of the heart. And essentially we've done this ourselves, and we've also looked at all of the literature that's ever done this before. And what you see after spinal cord injury is pretty much whichever index you take, the heart actually gets smaller after spinal cord injury. So the size of the left ventricle, which is the main chamber that pumps blood to the systemic circulation, gets less after spinal cord injury. In the blood vessels, there's many different ways you can assess health of the blood vessels. One of the most common that's emerging that's linked to cardiovascular disease is something called pulse wave velocity. So essentially what you do is you have somebody supine, you measure the blood velocity in the neck and in the leg, and then you basically look at the time difference it takes for that waveform to travel through the body. And so if you look here, the waveform is in the neck. A little bit later, it will arrive at the leg, the same pressure waveform. And if you look at the time difference and the distance, you can get an index of how stiff the vessels are. So a higher number here is worse. And we and many others have found that after spinal cord injury, the blood vessels become very stiff, which essentially makes them less pliable and less able to adapt well during exercise. There's also some really nice emerging work in the scientific literature from my colleague, Aaron Phillips. So here we have an individual with spinal cord injury that is on a tilt table. We can have them supine, and we're using the same device that Dr. Billinger just spoke about, this transcranial Doppler, and we can tilt them up and we can measure blood flow to the brain. And so when you tilt someone with spinal cord injury up, there's this exaggerated reduction in blood flow. They're not able to maintain blood flow. And we've been able to show that this is directly because blood pressure drops in the upright position. So as the blood pressure drops, blood flow to the brain drops. If we give a drug that normalizes blood pressure, we can normalize this response in the brain. So definitely some evidence that this reduction in blood flow in the brain is directly related to a lower blood pressure. The other thing we can do is using that same measurement of cerebral blood flow, we can have ask individuals to do a task, just something simple like opening and closing eyes. And as the eyes open, you can see blood flow would go up in an able-bodied individual. And after spinal cord injury, the magnitude of that increase is attenuated. And again, we can partially normalize this if we increase blood pressure. So lots of evidence that actually across the cardiovascular system now, in those individuals with high lesion spinal cord injury, we're seeing stiffer blood vessels, smaller heart size, and some impairments in the brain's ability to respond appropriately, especially to things like an upright tilt test. What I want to cover next is just some responses to exercise, but perhaps this is a good place just to see, Liz, is there any questions emerging just on those first changes to the cardiovascular system that occur after spinal cord injury?
Hold on, let me, I don't think regarding that, Patty, correct me if I'm wrong. I'm not seeing a question right now on that first part of your talk.
Okay, great. So what I want to cover next is just to go through some of the responses to exercise. And again, this is going to be specific to those with a higher spinal cord injury. Essentially, once you have an injury below the T6 level, the physiological response to exercise is almost what you would expect in an able-bodied individual. It's really, again, those individuals with an injury above T6 where the response to exercise can change. And it's important to understand how the cardiovascular system responds to exercise so that when it comes to exercise prescription, we have a better idea of what it is we should be prescribing. So let me just take you through this first graph here. So what we're looking at here is stroke volume. So this is the amount of blood pumped out of the heart with each beat. We're looking at this in individuals with cervical spinal cord injury and able-bodied individuals. And what you would typically see is that you start down here, and then as you exercise, stroke volume goes up. And what we see in spinal cord injury, again, is there's no increase in stroke volume. So stroke volume stays what it does at rest. Again, the reason for this is because those sympathetic nerves that go to the heart are no longer connected to the brainstem. So there's no ability to excite or increase. So stroke volume stays essentially what it does at rest. I should note that these able-bodied individuals, when they're exercising, are exercising at the same power output. So this isn't just a higher power output that they're getting to. This is for the same power output. Now, if we look at cardiac output, which is just stroke volume times our heart rate, you can see this response gets amplified. So able-bodied individuals can increase heart rate and stroke volume, so their cardiac output goes up quite markedly. And then individuals with cervical spinal cord injury, there is a small increase in heart rate, which allows this cardiac output to go up a little bit, but it's quite attenuated versus the able-bodied individuals. And this is the same whether it's arm crank exercise or wheeling on a treadmill. So the take home from this is that cardiac output is lower during exercise in those with spinal cord injury. One of the other things that happens after spinal cord injury is the sympathetic nerves don't only go to the heart and blood vessels, they also regulate the ability to sweat. And so what you're looking at here are individuals with either tetraplegia, so cervical spinal cord injury in blue, or paraplegia, so these are individuals with injury below T6 in green. And we're looking at two different things. Here's core body temperature, and here's skin temperature. And then we're doing different sets of exercise recovery, exercise recovery, exercise recovery. And so what you can see here nicely in both paraplegics and tetraplegics is as the exercise starts, core body temperature starts to go up. Into the rest period, it starts to go down in paraplegics and then back up and then down and then up and then down with exercise and rest. You can see in those with cervical SCI, again, this is very different. Core body temperature continues to go up because the ability to sweat is severely compromised after the high level spinal cord injury. This doesn't really have too many implications for most individuals if they're exercising inside in air-conditioned rooms, but this is certainly important to note if people are doing activity outside, anywhere that it's hot, especially in places like Kentucky. These would be things to be very mindful of, is that the core body temperature can go up considerably. In my lab, I'm just going to show this for those that are interested in how all of these systems come together to respond to exercise. So we're just going to focus on this top left panel over here to start with. This is a measure of VO2. This is the same measure that Dr. Billinger spoke about. Similar in spinal cord injury, this would be a VO2 peak value. And what we have here is just gradually increasing exercise stages and then peak exercise. And again, if you look at these values of VO2, the solid line is the cervical spinal cord injury. The dotted line is able-bodied. Typically, you would see this linear increase as power output goes up. And after spinal cord injury, this is markedly attenuated. In fact, these individuals typically only get to a VO2 peak of around 15 to 16 milliliters per kilogram per minute. So it's quite a low VO2 peak that people get to with arm exercise. And we're going to revisit this later when we talk about the types of exercise, because if arm crank exercise only gets you up to a VO2 peak of this, there's probably some implications from a cardiovascular disease risk point of view. These are just some of the other common things that we measure during exercise. So you can see as well, if you look at how much individuals with spinal cord injury are breathing, the ventilation is less. And the two ways you increase your ventilation are either by breathing faster or breathing deeper. So the interesting thing here is that spinal cord injured individuals, again, cervical SCI, they don't have good use of their abdominal muscles, which help with breathing. And so tidal volume tends to pretty much stay at resting values during exercise. And so individuals with spinal cord injury, when they increase their ventilation, they do it by breathing more shallow and more frequently to achieve the ventilation. Okay, the next part of the talk, I want to just move on to now looking at the effect of regular exercise to see how this impacts the responses to the cardiovascular system.
Hey, Chris.
Yeah, I was just going to stop for questions if there are any.
Yeah, there was a question. Oh, hold on, I've got it. It was about in regard to a statement you made a little earlier. The heart size in patients with spinal cord injury is reduced, or the overall capacity is reduced?
So if you look at heart size at rest, it is reduced. And then if you look at the capacity of the heart to be able to respond to exercise, that is also reduced. So it's both of them. There's both a reduction in size and less ability to respond effectively during exercise.
Here's another question. Do you think the VO2 lack of increase is due to the lack of sympathetic nervous response in regards to increasing blood flow during exercise?
Yes.
That was a simple answer.
I can tell you a little bit more about that. I haven't included this data for today due to time, but especially for those of you in Kentucky, there's a very large trial going on down there with epidural stimulation for people with spinal cord injury. We have some people in Canada that also have these epidural stimulators implanted, and we've tested those individuals. And so for those that don't know about this, you have essentially a stimulator placed on the surface of the spinal cord. It's placed surgically on the spinal cord. And then you have a control system that controls the frequency and the amplitude of that stimulator. And so you can use that stimulator to activate the nerves that are below the level of the spinal cord injury. And we and others have figured out ways that you can activate the sympathetic nerves. And so if we take somebody that has an epidural stimulator implanted and we exercise them without that stimulator, the VO2 is in that region of 13, 14, 15 mils per kilogram per minute. If we turn that stimulator on, then that exercise VO2 value goes up to about 21 to 22 milliliters per kilogram per minute. And that is the most direct evidence we have that it is actually the inability to activate the sympathetic nervous system that is causing, or at least contributing to, the lower exercise capacity.
That's it right now for questions.
Okay, great. So one of the things that my lab's been looking at now for the last 7 or 8 years is whether exercise and physical activity is actually able to offset some of these responses. And so you saw this device earlier from Dr. Billinger. There's actually a remarkable amount of overlap between the stroke field and the spinal cord injury field. And so what we actually did is we used these accelerometer devices to measure physical activity. We used them on the wrist because these were individuals that were manual wheelchair users. And in addition to using this, we also had GPS devices connected to the wheelchair as well. So what this uniquely enabled us to do is actually to be able to not only look at how active people with spinal cord injury are, but also to look at where they are getting their activity. Are they doing this, in a city center? Are they going to a gym to do this? And then what it's also able to do is you can overlay these data on top of each other. And so you can look at routes that people with spinal cord injury are taking around the community. And then you can break that route up into how much time is spent sedentary. And here it turns out this individual was coming from their home. They were driving. They drove all the way here to downtown Vancouver. And then they were doing some activity in downtown Vancouver. And so you can see this quite nicely here when they park and get out the car. And even just some regular wheeling is actually quite high intensity exercise for people with spinal cord injury. So we were able to do this in almost 20 people with different levels of spinal cord injury. We had some tetraplegics, we had some paraplegics, males and females were included. I should note that these were chronically injured individuals. So mean time post-injury was 20 years. So here was one of the more remarkable findings. Actually, when we looked at the amount of moderate to vigorous physical activity that people with spinal cord injury get per day, even with the accelerometry device, we had a pretty active sample. Most individuals were getting almost an hour a day, but note that there's a really high variation. So while some individuals were getting quite a high level, many individuals were still only getting around 15 to 16 minutes. One of the interesting findings is by looking at the GPS data combined is that we could split this up to look at how much activity was involving wheeling itself, so kind of transport or direct wheeling for fitness versus non-wheeled. And you can see in both cases, the majority of activity is coming through non-wheeled type activity. In the same study, we were able to measure heart function using echocardiography. And so what we were then able to do is relate different measures of cardiac function on the y-axis to the amount of moderate to vigorous physical activity. So the first thing to caution here is this is cross-sectional data. Each of these spots just represents an individual person. The open circles are those with cervical spinal cord injury. The closed circles are those with thoracic spinal cord injury. And you can see quite nicely, regardless of where the level of the injury was, those that did more activity tended to have a larger heart size and certainly a better stroke volume or better function of the heart. Now, that tells us cross-sectionally whether heart size and function is related to the amount of physical activity people do, but it doesn't tell us whether if we do physical activity or start people who haven't exercised in physical activity, whether it can improve cardiovascular health. And so we actually just completed, this was done by a Ph.D. student, Jasmine, who I supervise with Kathleen Martin-Guinness, who I've been involved a lot with. She's written a lot of the guidelines for spinal cord injury. And what we did for the first time is actually a very large clinical trial where we randomized individuals to receive either a control, so just standard of care, no intervention, or an intervention group. And the intervention group, uniquely, rather than doing structured exercise, was actually a 1 hour introductory personal training session, followed by 8 once weekly 15-minute check-in sessions. And these were behavioral activity coaching sessions. And this was called the Proactive SCI. This was something that was developed in collaboration with physiotherapists and occupational therapists to try and figure out a better way to get people to be active in their own homes and in their community outside of a gym environment. I should note that those that went into the control trial were waitlisted. So in the end, everybody got to receive this intervention. But I'm going to just show some of the results from the first part of this. We ended up with about 30 individuals that made it all the way through the 8-week intervention. So we had about 15 or so in the exercise or the intervention group and 15 or so in the control group. So we were actually able to show, and this is the first time this has been shown in the field of spinal cord injury, that the behavioral physical activity intervention was able to increase aerobic fitness. So again, just to reiterate, this isn't asking people to come into a gym environment and do structured exercise. There's been lots of work on that. This is a home-based physical or a community-based physical activity intervention. And pretty much every single individual, these are the individual points and the group mean, we were able to generate about a 15 to 16% improvement in VO2 peak. And for somebody that has quite a low VO2 peak to start with, this is a very meaningful increase. If you compare that to the control group, there was really no increase in the control group. So definitely some good evidence that this behavioral intervention is able to increase aerobic fitness or cardiorespiratory fitness. We actually went on to make a lot of further analysis with this, and we did some measures of vascular and cardiac health. We did 2 measures of vascular health this time. We have that pulse wave velocity, the same as before. And then we also looked at something called intermediate thickness. So this is where we're actually able to image the carotid artery, and we're able to look at the thickness of different parts of the arterial wall with ultrasound. Now, disappointingly, on any of our measures of vascular function, we didn't find any improvements in either group. When we looked at our measure of heart function, same thing. We didn't find any evidence of improvement. Some individuals improved, some, if anything, went down a little bit. So what this shows is that the behavioral activity intervention is good for improving cardiorespiratory fitness, but it didn't seem to have any impact on some of the more specific markers of cardiovascular disease. One of the other ways that we've tried to get at the question of how effective exercise and physical activity can be is actually to do some comparisons among individuals that are just community-based individuals with spinal cord injury and Paralympic athletes. So I realize this is a bit of a busy slide, but I'll break it down for you. So in this study, we have 3 groups of individuals. We have an able-bodied group that were matched for age and sex and body mass. And then we have a spinal cord injured non-athletic group. These are all cervical spinal cord injury. We had 15 people in this group, and then we had 15 spinal cord injured athletes as well. Again, they were matched for level of injury and severity of injury, age, and sex. So as close as possible, the only difference between this group and this group is how much they exercise. I should say that these were very high performance athletes. They were all part of the Canadian Paralympic team, and they were exercising upwards of 15 hours per week. Now, we made some measures of vascular health on this side and cardiac function on this side. And what you can see quite nicely is that the non-athletes have an increased value here. So increase is worse. This is a measure of, again, stiffness or elasticity of the arteries. So they have less elastic, stiffer arteries. And that's significantly improved, almost back to able-bodied individuals in those that are athletes. On the heart side, we again see quite a significant reduction in heart function in the non-athlete group. And then when we look in the athlete group, it's not quite back to able-bodied individuals, but it's trending to be better than the non-athletes. And with these two measures, what we're actually able to do is measure something else, which is how well the heart and blood vessels interact energetically with one another. And so in an ideal world, you want a value around 1, which means the energy that is produced by the heart is transferred effectively to the arteries. And what we saw is almost a doubling of this value after spinal cord injury. So it's like the heart and blood vessels are becoming uncoupled. There's a lot of wasted energy between the two. And this is starting to be linked as one of the kind of emerging values of cardiovascular health of the whole system. And then in our athlete group, we saw this reverse, again, not all the way down to able-bodied individuals, but certainly trending in that direction. And so what this suggests is that in the Paralympic athletes, so these are individuals that have been exercising for a long period of time and are exercising quite a lot each week, there definitely is the capacity to improve health of the cardiovascular system after spinal cord injury. So before we move on to the final section and talk about types of exercise and prescription and guidelines, I thought I'd just stop and see if there's any other questions on that part.
There is a question. What activities were you having the patients do in the, I'm guessing the behavioral study? What kind of activities were they doing?
Yeah, I'm going to talk about that a little bit actually in this upcoming section, but it really varied. Essentially, we had some individuals that were doing swimming. We had some that were lifting sugar bags at home. We had others that were wheeling out in the community. So it really varied. It was supposed to be pragmatic by design. So we were really open with the types of activities that we had individuals doing. We just wanted them it to be something that stimulated the cardiovascular system and something that they rated as moderate or vigorous physical activity. There was no restrictions on the type of activity.
Here's another question. For the thickness of the blood vessel walls, what time frame was the study conducted over?
So those individuals, it was a cross-sectional study again. So in our non-athlete group, individuals were a wide range time post-injury. They were all at least 3 years. So it was anywhere between 3 and I think the longest individual was 28 years post-spinal cord injury. The obvious next question to that was there any relationship between time since injury and those indices? And cross-sectionally, no, there wasn't. And not many studies that have looked at time since injury have been able to show associations with the cardiovascular indices. But what still hasn't been done is actually a long-term tracking study where we track the same measures in the same individuals over time. And we're just starting some of that work here in Canada now, where we're getting a bit of a registry together to try and track how cardiovascular system is changing in the same individual. The problem with the cross-sectional design is there's so many other variables that go into these measures that it can be hard to show some of those associations.
Okay.
Okay.
Yep.
So in the last part here, I wanted to touch on exercise prescription and some of the types of exercise and something we've become really interested in, which is actually even for individuals with spinal cord injury, is getting the lower limbs active as well. And so one of the students in my lab has been working for the last 2 or 3 years on a project where we've been looking at 2 different types of what we will call active arm, passive leg exercise. So for those not familiar with these types of machines, we have the New Step and the SciFit. And what these do slightly differently from one another is the arm and legs are connected by the same crank system. So on here, for example, as somebody is turning their arms, if the legs are strapped in, the legs get passively exercised at the same time, whilst the arms are actively exercising. And this is either done cyclically or more in a type of kind of extension, flexion type movement. And so what we had individuals do with spinal cord injuries, they would come in, they would do 2 different tests. They would first do an incremental exercise test to look at the effect on peak VO2. And then we'd do a submaximal exercise test at different percentages to see the effect at both submaximal workloads and on the maximal workload. I won't show all of the results today, but the interesting thing we were able to show is that for every individual, regardless of which two of these machines they used, when they do the active arm passive leg exercise, so APPLE as we call it, the VO2 increased by around 15%. So by engaging the lower limbs, even passively in exercise, there is an increased demand placed on the cardiovascular system. There was absolutely no change in heart rate between the two conditions. And so our estimation of stroke volume went up. And so what we think is happening is when you even passively engage the lower limbs, is that it actually pushes more blood back to the heart and allows you to increase your stroke volume during exercise. And if you can increase stroke volume, you can increase cardiac output, and that's what's explaining this increase in VO2 peak here. I will note that not from my lab, but others have shown that this effect is even more pronounced with FES. So this is functional electrical stimulation of the lower limbs. So in this study, they had individuals do arm crank exercise. So again, the average VO2 peak value here was around 12 to 13. If you just do FES leg cycling exercise, the average VO2 peak is much lower. It's down here. But when you combine the FES leg cycle exercise with the arm crank exercise, you can see I put a red line here across to make it a little easier. Again, there's about a 15 to 20% increase in the VO2 peak. They actually did two types of this combined. One of them was this hybrid exercise. This was done on a Berkel bike. This was just done out in the field. This one was done in the lab. And whichever of these two types of hybrid exercise, both again showed the same thing, that if you can engage the lower legs in exercise, then you can increase the VO2 peak. I say it's even better with FES. There hasn't actually been a good study that's compared the passive lower limb exercise with the functional electrical stimulation. But I suspect because you're actually stimulating the muscles themselves, you probably get more additional peripheral benefits with the FES versus just the passive leg exercise. And certainly the VO2 peak values do appear higher with FES. So this seems like the best combination. If you can have access to the functional electrical stimulation, not everybody has access to this. It can be quite costly. It requires a specialized setup. It also requires kind of 8 to 10 week build-up program to get the legs used to being stimulated again and to make sure they won't fatigue in order to be able to exercise long enough. So if you can't do the FES, then certainly doing the passive lower limb exercise is still better than just arm crank exercise when we're talking about the stress placed on the cardiovascular system. And again, no real difference in heart rate across these three, again, suggesting that by activating the lower limbs, you're increasing your stroke volume. And so the question always becomes, well, how much exercise do I prescribe? And so myself and Dr. Kathleen Martin-Guinness, who I mentioned before, actually went through a really big literature review. We did a full systematic review of the literature, identified over 13,000 studies. We ended up at about 200 to 210 studies that have actually done exercise interventions in people with spinal cord injury. We convened an international panel from people from Europe, Canada, the US, Australia, South Africa, were all on these guideline committees. And after reviewing all of this, we actually came up with some scientifically valid exercise guidelines for spinal cord injury. There's actually two. I'll get into why there's two. The main one, which is this top one here, and this is the one that's been taken forward to the community, is that for fitness benefits, individuals or adults with spinal cord injury should engage in at least 20 minutes of moderate to vigorous physical activity, aerobic exercise twice a week, and 3 sets of strength training of each of the major muscle groups, 8 to 10 repetitions twice a week. I will say, because these were evidence-based guidelines, we actually split the guidelines depending on if there was evidence to support it for a fitness benefit versus a cardiometabolic health benefit. And the two are a little different. But certainly for a fitness benefit, this is the main guideline. It seems from the literature and from everything we've done in my lab that just doing the 20 minutes twice a week probably isn't sufficient to change cardiovascular or cardiometabolic health. You probably need something either more intense or something of longer duration to get the cardiometabolic health benefits. So these were the scientific guidelines. we ended up translating this to a community guideline that looks like this, where we have this starting level where everybody should be engaging in, again, 20 minutes twice a week, plus the strength activity, and then moving towards this advanced level. We were cautious to recommend this to start with. Many individuals with spinal cord injury would find it really hard just starting straight at this level. So we've put this in as a starting one to aim for, and then to try and get up to this level, and then if anything to exceed these as well. What types of exercise activity? Again, just a few things to be aware of. It shouldn't all be about wheeling. Shoulder pain is pretty prevalent in wheelchair users, and carpal tunnel syndrome is also pretty prevalent in wheelchair users. And so really physical activity and exercise can take on many different forms. And when we're thinking about pragmatic ways for people to exercise, not everybody can come into a lab, or not everybody uses a manual wheelchair. And so it's good to try and think about different types of exercise that people can get. There is some emerging evidence, not enough yet to make any recommendations on this, but certainly lots of people have started looking at the high intensity interval training for exercise. This was a review that's just done. I will caution that although practically every single one of these studies has found a benefit in VO2 peak and everything they've looked at, all but one study has found a benefit. None of these studies have been particularly well controlled from a clinical trial perspective. And so this is why the HIIT exercise didn't make it into the recommendations, because there hasn't been that level of control in these trials that we would usually look for. That's not to say these are not valid at all. There's some really good emerging evidence that HIIT, and it can be done many different ways at different percentages of power outputs or RPEs, for different amounts of time. They all seem to show a benefit. So this is some really promising evidence. I often get asked how to best prescribe exercise. And so one of the things that Jasmine, that PhD student that I mentioned, did during her PhD is actually put together a toolkit for physiotherapists. I've made a link here, and I can pass this link on as well. This is essentially a 50-page PDF that goes through absolutely everything about how to prescribe exercise for people with spinal cord injury, what types to do, how to monitor intensity, how to start, safety, physiological responses. Goes through how to deliver a behavioral intervention and the different things that should go into that as well. So this is a really useful toolkit for anyone looking to prescribe exercise or physical activity to spinal cord injury. I often get asked about how to monitor intensity. As you'll remember, because in most individuals, certainly those above T6, the heart rate response to exercise is massively dampened. So this means you can't use heart rate as a good way to monitor exercise intensity. So what's pretty much emerging now as being one of the best ways to do this is actually being able to just use the ratings of perceived exertion. I'll just flick over to this. For those that don't know what this is just a simple 1 to 10 scale. We use the 1 to 10 rather than the 6 to 20 scale. The 6 to 20 scale was originally linked to heart rate, and that link doesn't work after spinal cord injury. And we've also found it is a little harder for people to comprehend. A 1 to 10 scale is much more straightforward. And so we and others have started using this RPE scale as a way to monitor intensity. And this is really just to show that whether you impose a power output on an individual with spinal cord injury for 20 minutes, or you ask them to then self-regulate using RPE, the two pretty much overlay each other quite nicely. And so once people get used to using this RPE scale, it's been shown to be pretty effective at being able to impose a set work rate for individuals with spinal cord injury. I'll just note that if anyone else is interested in this, myself and Kathleen, again, we just published a paper that will talk through going from the origin of the guidelines to practice on how we develop these and how they're now being implemented in the field of spinal cord injury. This has just come out. And then I just wanted to finish just with a couple of points on safety. Exercise does many things to the cardiovascular system. One of the important things is as the blood flow increases, when you stop exercising, that blood flow can end up pooling in the lower part of the body. So it's quite important just to be careful of both postural hypotension, but also post-exercise hypotension for people with spinal cord injury. Again, everybody should be aware of autonomic dysreflexia. This can occur during exercise. should be aware of how the core temperature might respond in different environments, and certainly be careful not to be too cold and equally not to be too hot as well. There's also, and I didn't have time to talk about this, but you should always be checking for any evidence of skin breakdown, especially if people are exercising in the same position for a long period of time. And then I mentioned again with overuse injuries coming from excessive just wheelchairs. People with spinal cord injury using their upper body and their arms for everything. So it's just a word of caution about being careful not to prescribe too much for overuse injuries. There's many different ways out there and many things out there now that can help people with spinal cord injury to exercise. There's these gripping aids. So many of those individuals with cervical spinal cord injury will find it hard to grip onto exercise machines. These are actually developed by someone I know back in the UK. So these are probably some of the better ones that are out there. You can get cheaper versions of these now as well. But essentially these help to provide gripping aids so that people with spinal cord injury can use resistance machines or some of the other machines in the gym. It's often useful to keep some kind of water spray, especially if the environment is hot, so that you can keep cool. And just to reiterate again, to try and keep an eye on blood pressure as best as possible when exercising. So just bring this together. So the important thing to remember here from the talk is, cardiovascular function does not necessarily tie in with motor and sensory function. So you can have someone with a motor and sensory complete injury, but their cardiovascular system may or may not still be intact with their brain. We've collected data, and so have many others now, that suggest that short-term exercise and physical activity is able to improve fitness, but it's probably going to require continued exercise over many years, or perhaps exercise at a higher intensity to reduce the risk for cardiovascular disease. Certainly the data that we've collected in the high performance athletes suggests that those athletes have a more healthy cardiovascular system. So there's definitely the capacity to still improve after spinal cord injury. And just the take home message really is that despite what you may hear, like, people with SCI can and very much should be engaging in regular exercise. So with that, I'd like to thank all the members of my lab that have helped contribute to this, and all of the funding agencies as well that have supported this work, and I'll happily take any questions with the time that's left.
Thanks, Chris. I really appreciate the information. It's incredibly interesting. I mean, I have a spinal cord injury, so of course it's interesting to me, but it's, I think, really valuable. There are some questions. One, I wonder if you could cut and paste that link to that PDF and maybe put it in the chat box right now. I mean, I can put it on our website later, but if you cut and paste it in the chat box, that might work.
I can put that in the chat box. There's also a link that I can put in there to the spinal cord injury guidelines website as well, which is hosted through our university, UBC. So I can put the link to both of those into the chat so people can access them. I'll do that as soon as the questions are finished. Okay.
And then here's a question. If using the RPE scale 1 to 10, what number do you recommend the exercise in?
It depends how accustomed to exercise they are. Ideally, we would like to see them get up to a 6 to 7.
Okay. And then with the lack of sympathetic nervous system output in spinal cord injuries above T6, does aerobic activity still shift metabolic activity during cardio, specifically when switching from burning glycogen stores during anaerobic to lipids and fats during aerobic?
That's a really good question. In terms of substrate utilization during exercise, we're only really just starting to understand that now. Actually, Mark Nash at the University of Florida has done most of the work in this area, looking at substrate utilization. There's certainly evidence that people with spinal cord injury probably rely more on glycogen and the carbohydrate metabolism. But again, that can vary wildly with training status as well. So we've tested some of the individuals. We've tested the person that just won the London Marathon in the wheelchair, and they're quite effective at being able to use fat as a substrate. So again, a lot of it, similar to able-bodied, will come down to training history and environment. But there is a thought, yes, that those with higher injuries probably will rely more on the glycogen systems.
Okay, I think that's the last question I have here. Chris, if you'll stop sharing your screen for a second.
Yes.
And I can, again, thank you so much. I appreciate you. You're several hours behind us, getting up a little earlier than the rest of us to join us and provide all this valuable information. I'm going to share the screen and do these questions again, folks. So if you paid attention, the first person to correctly answer will win a prize. And again, you go to polev.com/jjones. And if you haven't done it before, you'll get that pop up and you click not now. And then we will move to the question. First question, whoops. Oh, shoot. Whoop. My goodness. Sorry, folks. Okay. Wow. Well, you all are answering before I even put it up there. I guess it's already gone. How many minutes? Is this right or is this Sandy's? That was Sandy's, wasn't it? Oh, sorry, folks, I had it. Okay, here we go. What are the physical activity recommendations for people with spinal cord injury? A, at least 20 minutes of aerobic exercise twice per week, plus strength training, at least 45 minutes of aerobic exercise twice per week, plus strength training, or at least 20 minutes of aerobic twice per week only. People are going, people are answering. Whoop. All right. Most people got it right. Correct, Chris? I did that right, didn't I? Yep. All
Yes, that's correct.
And then we have guest 376. So look up at the top of your screen, you'll see your guest number, and then tell us in the chat box who's guest 376. And we will go with that. And then the second question, which of these exercises is likely to elicit the highest strain on the cardiovascular system? FES cycling, body weight supported treadmill training, arm crank exercise, or FES cycling plus arm crank exercise? Okay, we're getting close to the end. Here we go. D is the correct answer. And guest 768, tell us who you are in the chat box. We're on the honor system. So guest 768, put your name in the chat box, let us know. We are going to, I'm going to